let's dive right into this explainer and look at a total paradigm-shifting reality about tuberculosis survivorship. For decades, medicine's entire relationship with TB was organized around just one simple driving question: how do we cure it? The basic assumption was that once a patient finishes their antibiotics and the bacteria are cleared, well, the story's over. But there's a massive shift happening in global health right now, asking a second question that honestly used to be a total afterthought. What do those lungs actually look like for the rest of that patient's life, long after the bacteria are gone? Today, we're going to build this whole post-TB picture right from first principles. Just think about this number for a second. 20 million. Let that massive scale sink in. Globally, there are roughly 20 million people who have successfully beaten TB, but are now living with permanent, measurable lung damage. Their cultures are negative, their drug regimens are completely finished, and on paper, they're technically cured. Yet tuberculosis has this hidden life sentence built into it. That physiological sentence continues long after the penalty for the active infection itself has been fully served. It leaves literally millions of people struggling to simply breathe in the aftermath. So the absolutely crucial point we need to grasp here is that beating the bacteria does not mean fixing the lung. A microbiological cure and anatomical restoration are two completely different things. Think of an active TB infection like a raging house fire. The combination of the organism's toxic effects plus the host's own intense immune response causes immense tissue destruction. Now, taking antibiotics, that's like putting out the flames. Yes, the fire is gone, that's your microbiological cure, but the house is still burnt down. When treatment successfully eliminates the organism, that deeply damaged pulmonary tissue simply doesn't just magically regenerate back to normal. Section 1. The anatomy of permanent damage. So once the organism is finally eliminated, that severely damaged tissue still has to heal, right? And it does so by fibrosis and scarring. This physical process literally causes the lung to contract and lose overall volume. This is just the body's standard repair response to any severe, destructive tissue injury that it simply cannot regenerate. But the real issue is that scar tissue acts like a tight, unyielding net. It physically pulls, shrinks, and collapses the surrounding delicate lung tissue inward. The infection itself is completely gone, but this architectural damage it left behind, it's often permanent. And it's exactly this permanent mechanical damage that produces every single finding you're going to encounter when examining one of these patients. Actually, once you understand this concept of volume loss, every single physical symptom on an exam just becomes a brilliant logical deduction because fibrotic tissue is constantly shrinking. The chest wall on the affected side physically depresses, essentially settling inward around the permanently shrunken lung. You'll see significantly reduced chest expansion because, well, scar tissue is stiff. It just doesn't expand when the patient takes a breath. Even the trachea is physically pulled toward the affected side by that exact same vacuum-like volume loss mechanism. If you tap on the chest, you'll get a dull percussion note from the reduced airspace. And listening, that yields decreased breath sounds because dense scar tissue transmits sound very poorly. You might even find old surgical scars if the patient was treated with a lung resection back in the early antibiotic era. Section 2. The Diagnostic Acoustic Paradox. Now, this brings us to a deliberate paradox in the physical exam that you really need to watch out for. You have to ask yourself, how could fibrotic volume loss possibly result in bronchial breathing, increased vocal fremitus, that vibration you feel on the chest when a patient speaks, and increased resonance? These are the classic acoustic signatures of consolidation. Consolidation usually implies fluid or organized pus in the lung, like you'd see in pneumonia, definitely not simple scarring and collapse. It seems completely counterintuitive, especially when we just established a minute ago that tight scar tissue decreases sound transmission. Well, this brilliantly illustrates the mixed pathology of a post-TB lung. It isn't just a single, clean process, but rather a wildly complex patchwork of dead scar tissue sitting right alongside chronic consolidation. The dense, dead scar tissue behaves acoustically like a collapsed lung, giving you those dull, quiet signs. But right next to it, you can have areas of chronic organized consolidation type change, which actually transmit sound incredibly well. This is exactly why you get a mixed acoustic profile. Real post-TB lungs are rarely uniform. They're a complicated, overlapping patchwork of different pathologies right next to each other, making the physical exam a really fascinating challenge. Of course, when you see unilateral fibrosis, TB is absolutely the prime suspect. But you can't just close the case right there. You must actively work through a differential diagnosis. Even though post-TB remains the single most common cause encountered in clinical practice, you cannot just assume it by default. You have to consider other culprits, like post-bronchiectasis scarring. You also need to actively ask your patient about any prior radiation treatment for lung or breast cancer, which often leaves distinct fibrosis confined strictly to the irradiated field. And while it's genuinely uncommon, you always have to keep ankylosing spondylitis in the back of your mind, since it classically causes severe fibrosis right at the very top of the lungs. Section 3. Expanding the PTLD spectrum. So the crucial takeaway here is that this localized scarring is just one piece of a much larger, increasingly formalized clinical entity called Post-Tuberculosis Lung Disease, or PTLD. The medical field has fundamentally shifted to recognize PTLD as a distinct, actively studied condition for this massive global population of TB survivors. And this is a huge paradigm shift in global health. For decades, billions of dollars and millions of hours in healthcare focus went almost entirely toward the cure. But now, national and international respiratory societies are building dedicated clinical guidance specifically for the chronic respiratory consequences that stick around long after that cure is achieved. This spectrum spans several varying manifestations. Looking at the airway category, scarring can lead to severe tracheobronchial stenosis and bronchiectasis. Over in the fungal category, residual TB cavities can actually become colonized by secondary aspergillomas, which frankly are literally just massive fungus balls growing in the empty lung spaces. You absolutely always have to consider this if a survivor presents with hemoptysis or coughing up blood. Pleural disease leaves chronic thickening, and functionally, it is genuinely amazing and slightly terrifying that encountering obstructive lung disease in a lifelong non-smoker with a prior TB history should immediately point you to TB-associated COPD. The airway obstruction is driven entirely by the destructive remodeling of the past infection. 0 cigarette smoke required. Section 4. Staged long-term follow-up. To manage this massive global burden, clinical guidelines now recommend a highly structured, staged follow-up approach. This timeline clearly demarcates the immediate priority of checking for relapse and stopping smoking, right from the longer-term phase of individualized management. In those crucial first 12 months, the absolute focus is on catching disease relapse, monitoring the evolution of airway scarring, and heavily enforcing smoking cessation. Why is smoking such a massive issue here? Well, their lungs are already structurally compromised and clinging to whatever function they have left. Adding cigarette smoke to that fragile architecture accelerates the drop-off in lung function exponentially. Then, once you move into the long-term phase, management shifts entirely and becomes completely individualized, specifically targeting whatever unique manifestations have emerged for that particular patient. Beyond the direct PTLD spectrum, chronically damaged lungs carry some severely elevated long-term risks that demand active, persistent screening. Because the airways are structurally abnormal and just don't drain well anymore, these patients are at extremely high risk for recurrent bacterial infections. If the structural damage is extensive enough to cause chronic low oxygen levels, it can lead to cor pulmonale, which is right-sided heart failure. And perhaps most critically, there is a notably elevated risk of lung cancer occurring right inside those areas of chronic TB scarring. This happens because the state of chronic inflammation and dense scar tissue acts as a perfect breeding ground for dangerous cellular mutations over time. Let's pause here for a second because this is a vital clinical pitfall that you need to be specifically warned against. The elevated lung cancer risk means any new nodules in old cavities must be actively and promptly investigated. If you see any new localized change on an X-ray in a previously stable scarred area, maybe a new nodule or a change in the wall of an old cavity, it deserves immediate aggressive workup. There's a huge temptation to look at a messy, heavily scarred X-ray and just reflexively wave it off as old TB changes. Do not do this. That assumption can quite literally cost a patient their life. Section 5. Rethinking TB survivorship. I want to pull this whole picture together and leave you with a provocative thought. It's a reminder that for millions of people worldwide, this disease never fully lets go, even after the cure is completely finished. The organism itself might be eradicated, but the immense tissue destruction and immune-mediated damage it caused remains locked in the chest. The permanent fibrosis, the mechanical volume loss, the airway stenosis, the cavitary fungal disease, and the smoking-independent COPD. This is a genuinely under-recognized consequence of a disease that most of the world, and honestly much of the medical community, still thinks of purely in terms of an active infection being successfully cured. So, did this explainer change how you see TB? If you found this structured breakdown helpful, make sure to like, comment with your thoughts, suggest new topics, and subscribe to the channel. Let us know down below if this changed your perspective on what it means to actually survive tuberculosis. And please drop your suggestions in the comments for the next medical mystery or complex topic you want us to unpack next. Thanks for diving deep into the science with us, and keep exploring.